Hi guys, Dr. Gillard again. Today we're going to make up that lecture that we missed last week because of Turkey Day. And this will be on spondylolisthesis spondylolysis. I've also put the quiz that I usually give you on a different video. I suggest you watch this one first and then take the quiz. But make sure you watch both of these because this is fair game for the final, and this is actually a very important topic. All right, here we go. So, what's the best place to look for spondylolysis or spondylolisthesis? It's actually a CT scan, a mid-body cut. We're usually used to looking at cuts right through the disc level here, right? We're getting pretty good at that, but we're not very good at looking through the body. Now this is that orange line like I showed you last week. This is the cut line. So this is a cut through the sagittal view. This is what we're seeing here. So we have, we'll call this L3 vertebral body here. And now these are the L3 pedicles here. Remember now, in the views you're used to seeing, we see the neuroforamina here, but now we can't see them. We're seeing the top of the neuroforamina, which is the pelvis here. Anybody, or what's the pelvis? Are the pedicles here. Now, what type of view is this? This is a CT scan, as I just said. So, anybody see anything weird with this view? Well, if this is a CT scan, it's like X-ray, right? We usually don't see soft tissue. But then what are these little dots here? Good, good. A couple of you got that. Those are the nerve roots that hang within the thecal sac that make up the cauda equina, but we shouldn't see them, right, in a CT scan. That's because this is a CT myelogram. So all this white here, this is not a T2 weighted MRI. This is all contrast, which is a stuff they inject into the thecal sac, and it makes stuff that's occupying space show up as dark. So we can see some of the nerve roots here. So that's in case some of you were wondering. All right, why is the mid-body a good place to look for spondylolysis? Well, where's the pars interarticularis would be right here, right? And look, so what's this? There's a spondylolysis, pretty good size one here, maybe even a little slip here. So it's a bilateral spondylolysis right through the pars interarticularis. Okay, a little bit of anatomy here for you. Again, if this is the L4 superior part of the vertebral body, that means we're a few slices down from which disc? From the L3 disc. So if this is the L4 vertebral body, now we have the pedicle, which we just saw before. Now the only thing different about this view, normally this would be the facet from below coming up, but now this is actually the superior articular process of L4, the same number. Now if this was a disc level cut, we'd see the superior articular process from the vertebrae coming up from below. So that's the only difference here. So the inferior articular process of L3. Transverse processes, spinous process, laminae are right here. This is the vertebral canal. This is the thecal sac. Para-Sagittal anatomy is this. What is para-sagittal? We had a little trouble with that actually this week. Para-sagittal means we have a cut not through the middle. It's still a view from the side, but not a perfect cut through the middle. This is off to the side. So in such a way that you can see these holes, which are the neuroforamina, aka intervertebral foramina here. So where's the pars interarticularis? Well, let's see, what do we have here? This is the pedicle, this is the body of L5, pedicle is here, and then this is the superior articular process, all of this, right? Here's the inferior articular process from L4. This is the facet joint, or the zygapophyseal joint, or the Z joint. This is the inferior articular process, now we can see, of L5, connecting with the superior articular process of S1. There's the inferior facet joint. So this space right here, right in between the superior and inferior articular processes, that's the, what is it? The pars interarticularis. Okay, here's a cartoon just to show you this concept, which is an important concept for today. So what do we have? What's going on here? You guys see it? So we have a fracture right through the pars intra-articularis of L4. How's that one look? That looks good. This one looks good. Well, some of you say, what's that white stuff there? That might be something called reactive sclerosis. We're going to talk a little bit about that. So that pars is obviously under some stress. Here's a normal one. You can see the cortices and more of the medullary portion would be right here. All right, so let's get to some basic stuff now. This might be a little dry, but we need to get through this. So what is a spondylolysis? It's a break in the posterior arch of the vertebra. This break usually occurs in the weakest part of the bone, which is, of course, pars intra-articularis. So where's the pars intra-articularis? Here. What the heck is this? So this is a reformatted three-dimensional CT scan, which is pretty cool. So it's almost like a Scotty dog, like an oblique view. Well, it is an oblique view. So here's the vertebral body. Let's look at this one. Here's Scotty dog. There's his ear. His eye would be the pedicle right here. There's his neck, so that's the pars. Okay, there's the lamina here, spinous process, disc space. So we're looking in this region right here in the neck. Looks pretty good right here. How's this one look? Not so good, right? That's a spondylolysis right there. Okay, so this break usually will occur in the pars intra-articularis. Once the pars breaks, the key with this is the stability of that vertebrae may be compromised, right? Because this is the solid ring of bone is supposed to be here. We're not supposed to have any breaks in it. So we might have micro motion or macro motion. We may have some visible slip on plain film. But this micro motion that might not be visible may be a source of chronic pain in some patients. Now typically the slip is anterior, so that's called a spondylolisthesis. If we get a slip of the vertebral body, we'll talk more about that. Or an anterolisthesis. I prefer spondylolisthesis. But sometimes you get a lateral slip. You can also get a lateral slip, which is usually combined with some rotation. So here's a nice example. This is an A to P view or a coronal view. So here's the vertebral bodies we're looking at. This is a cut right through the bodies. And notice the sagittal or the alignment from the sides is fine here, but look what's happened here. So this vertebrae, this whole stack actually has slipped off to the left of the picture here. And you can see it's been going on probably for a long time. The body's trying to stabilize this region naturally. This is all bony sclerosis where you see it's white here. These are not modic changes. This is a CT. Then we have the rat bite erosion and the disc space narrowing. Oh, that rings a bell, doesn't it? We just talked about that last week or this week. What is that? That's called isolated disc reabsorption. Okay, let's see so if you're not sure that the posterior arch is fractured and you are sure that the slip is not secondary to facets, elongated pars, or dysplastic or hypoplastic articular process, then you may technically call this a spondylolytic spondylolisthesis. So that's a very descriptive term that in real world is not, I don't think I've ever seen it used. Well, maybe I shouldn't say that, but you don't need to really say that. But if you want to get technical, I guess you could say that. Okay, so it's vital that the motion segment remains stable. We just talked about this. You can read through this. We just said it can become a source of irritant, right? If you have micromotion or macromotion of that fracture area, it can become a source of chronic pain. So what's a good definition of instability? I like this. It's a loss of motion segment stiffness that occurs during normal body motion and axial loading. Okay, and then we talked about this already. I think we got the message there. So we've been over this before as well. To ensure that a vertebrae is stable and not slip sliding around, you must at the very least order a flexion extension fit series and a lateral bending series. These should be done weight bearing, right? They should not be done prone. I don't know how many of these I've seen prone, or I'm sorry, in like a recumbent position. These have to be done weight bearing, which will put a little more stress on the segments, increase your chances of seeing a slip. And obviously, grade 5 chiropractic manipulation on an unstable motion segment is absolutely contraindicated because it could really hurt the patient, not to mention get you sued. Instability is best diagnosed and we said that already. So what do we got here? Yeah, these are flexion extension studies. So if you look at this one, we can see we do have a grade 1 spondy here. Right, so here's the back of S1. These all look pretty good alignment, right? I could draw a line right down the back here. But this one's definitely poking out. So if this was unstable, it would have to slide more than 3.5 millimeters, depending on the source. If it slides more than 3 millimeters, you got to raise an eyebrow. So we can eyeball that, and you can see there's not, I don't see much slip at all. So this is a stable spondylolisthesis at L5. I even drew the lines in there. You can see how we have a break in this line. You can also do these images in a upright MRI. I'm just not a big fan of these. You know, they were really popular last decade. You know, they're touted to show a lot of things that conventional MRI miss, but there's a trade-off. The Tesla, which gives you the clarity of the picture, is quite low, usually 0.5, maybe 0.75 these days, compared to 3 Tesla. I mean, it's night and day. And I just not a fan of these things unless you're absolutely at the end of your diagnostic rope. You can't figure something out, then I would maybe order one of these as a last ditch effort. Types of instability. Okay, now we have, this is important stuff to know. There's sagittal, anterior, posterior translational instability. That's the one we're used to. That means there's a slip going forward and backwards. Typically, in California, we use the AMA Guides 5th. It's great. Anything greater than 3.5 millimeters means the patient is unstable. Not a good thing. This one you may not be familiar with, and you should be familiar with, the sagittal angular motion instability, or aka angular motion instability. There's a bunch of AKAs. Now this means that the instability is not slip sliding forward and backward. It's not slip sliding laterally. It actually occurs during flexion or extension. It's usually occurs during flexion. When you bend forward, there's been some type of damage to the ligamentum flavum, the interspinous ligaments, and it allows the vertebrae to fan too far apart. So I'm not going to hold you responsible for those numbers. You should know this one though. 3.5. Know that one. We don't care about these. It's because it's fairly rare for you to find something like this. But I think the reason it's fairly rare is a lot of people don't even take the images. Here's a translational instability here. Here's an extension view. You can see I can eyeball it. We probably got about maybe 2 millimeters of slip. Then we go into the flexion mode, and now we got a lot more slip. That's probably 5 millimeters. Oh, there's the answer right there. There's 5 millimeters of slip. There's about 2 millimeters. So this patient would be unstable or unstable at L4, L5. So you would not adjust this patient at least with grade 5. Angular motion instability is now when we flex forward. So here all the interspinous ligaments are ripped. Ligamentum flavum has been ripped. The disc has been, there's a huge annular tear, and you get a giant fanning of the spinous processes. Okay, I put this one in there. This is very rare, but here's one person who had a extension injury, so his anterior longitudinal ligament was ripped. So when he bends forward, when he bends back, you can see there's usually not much gapping here, but now there's a lot of gapping, so still angular motion instability. All right, let's now get into discussing spondylolysis a little bit more. Obviously, not a great position for the low back, right? That's severe extension, and you can see that's going to stress the pars as well as the disc. So spondylolysis, one of the most common causes of low back pain in adolescent athletes. Let me say that again. You're going to see adolescent wrestlers and gymnasts and track and field discus throwers. It's one of the most common causes of low back pain in adolescent athletes. And this is classified as an acquired stress fracture of the pars. This is not something they're born with. Let me repeat. That's an old, we used to think that a long time ago. They are not born with a spondylolysis. This is something that is acquired after birth. And we'll talk about Fredrickson and Beutler, or actually a little bit about it right there. They're virtually never seen at birth. They performed x-rays of 500 brand new spanking newborn babies in a row. Don't ask me how they ever got permission to do that. We would never be able to do that study these days, but they did it. Not a single spondylolysis in 500 babies in a row. So if they occur, it's very rare. Now you can have a genetic or hereditary weakness of the pars intraarticularis. We're going to see a hypoplastic pars in a little bit. So it can be genetically predisposed, but it's still an acquired stress fracture. So the majority, based again on Fredrickson, we have learned the majority of these occur in the first decade of life, between 0 and 10. And a lot of times they're not symptomatic, at least at first. But, again from the Fredrickson study, over 50% of them actually will turn, over 50% of spondylolysis without slip will turn into a full-blown spondylolisthesis by the third decade of life, right? By the 40s. Okay. Approximately 25% will become symptomatic. So most of them, again, are not symptomatic. So how does a spondylo, we said it's an acquired stress fracture. How does it happen? Well, there's 3 stages that you do need to know. So it's considered a stress reaction, the first step is a stress reaction. This is not seen on X-ray or even CT. Now, MRI may catch a mild patch of edema here, but low sensitivity. That means it's not very good at picking these out. Diagnostic accuracy is not the best. So you could order a bone scan if you had to, but this stress reaction is the first. Usually we can wait this out and it'll heal. You'll never even know the patient had it if you restrict them from doing things that could be aggravating this. But if things keep going, then the next phase is you get a disruption of the cortex of the pars intraarticularis. So now we have a real stress fracture. This, I guess, could be considered a stress reaction. This one a stress fracture. So you can usually see this on plain film. Thin slice CT is ideal. Of course, the radiation is much higher. So if you can see it on plain film, there's no reason to order a CT. And then but if you do a flexion extension radiograph, it'll probably be normal. So the next worsening, let's say it's a young athlete and he doesn't listen to you and he keeps wrestling, keeps doing gymnastics, treatment doesn't get better. Now we're going to have a separation of the pars. That means we have a forward slip. So now we have a spondylolisthesis, right? Or if you have to call it a spondylolytic spondylolisthesis, then fine. But spondylolisthesis implies some type of slip. So still probably stable on flexion extension x-rays though. So these are the phases that we usually catch, these two. Now, if the athlete just keeps going, he's got to compete, or what have you. Sometimes you can get the pars slip even further, or sometimes it doesn't even have to slip; it just doesn't heal, and that's this a non-union pars, and that's the end result. Now, these may be uh, unstable on flexion extension radiograph, and it can't heal. May become a source of chronic pain so bad that you may have to fuse it surgically. Let's talk a little bit about reactive sclerosis. I mentioned it before. A great example occurs in a unilateral spondylolysis, which we have right here. What does that mean? Unilateral spondylolysis. That means that only part of it is broken. So on the right here we have a fracture through the pars, but not over here. But what has happened over here? Look at the thickness. Okay, this is normal. So why is this so thick and so white? Well, we broke the pars. We broke this stress axial load carrying part of the vertebra. So now this guy takes on double duty, and when the body feels abnormal stress, increased weight bearing, it starts to beef up. Body lays down more calcium. This would show up as hot on a bone scan, by the way. So this is called reactive sclerosis. There's also reactive sclerosis at both ends of the fracture as well. So pretty cool picture. These are pretty rare, by the way. I don't see them. When they do occur, they're bad news because they don't typically respond well to conservative care. Let's see, I think I got all that. You have to watch out. They do look like an osteoid osteoma or an osteoblastoma. Sometimes you can't tell the two apart, which typically affects the pedicle. So you have to be careful with those. Osteoblastoma, or osteoid osteoma, what's the key finding? I think I was just reading on this the other day. I think 85% of all patients, when they report symptoms to their doctor, what turns out to be an osteoid osteoma, 80% or 85% have noticed that if they take aspirin or an NSAID, it gives them almost miraculous relief of their pain for a few hours. So it's a very strange finding, very pathognomonic of osteoid osteoma. I digress though. Try to stay on point. But here's osteoid osteoma right there, hot on a bone scan. It's picked up the markers, radionucleotides, I believe they're called. We won't get into all that today. There it is there. And here it is here. Look at how it's really, look at the pedicle here, and look at this. This is all osteoid osteoma. They love the posterior arch and the sacrum. Spondylolysis location likely will occur at the L5 pars interarticularis. Loves the L5 pars. Look at that, 85 to 9% of the time in this study. Only 5 to 15% at L4. It's very rare to see elsewhere. Kind of like disc herniations, only more rare to be seen up higher. High risk sports, there's my favorite sport, hammer throwing. Any rotational sport where you're rotating, look at the twist. The disc hates to be twisted. The pars hates to be twisted. Discus would do the same thing. Rotary shot put. I think I got a list of these, like a cricket. Oh, here we go. Fast bowlers. That's those guys who throw the ball to the batter on the ground. Very high risk, 27% point prevalence. What's point prevalence mean? That means if you just take a portable scanner out and grab 100 fast bowlers, 27% of them, or not actually, if you shoot ones who have participated, some of them may be so sore they're not participating. Whether participate or not, about 27% of them will have a spondylolysis. Look at this for track and field, the throwers, hammer throwers, discus throwers, 27 to 48% in one study, which is crazy. Back when I was throwing a hammer, our number one thrower, I had a good spondylolisthesis, which was quite irritating to him. So they're very common Weightlifters 23%, gymnasts 16%. I've seen higher studies than that. American football players are in the 20s as well. It's called the snatch, Olympic lift, a lot of stress on the low back there, not to mention the shoulders. So risk factors, what are the risk factors? So movement factors, make sure you know these. Movement factors of spondylolysis, anybody who does repetitive axial loading, extreme hyperextension, like that guy we just saw, or like gymnasts, even better, repetitive rotation, hammer throwers, discus throwers. Now, spinal structure abnormalities can uh, act as a risk factor as well. One is hypolordosis. Let's get that back. Hypolordosis or anterior weight bearing. See, here we have a line. We're going to talk more about this in a minute. But there's that old line. I think it's Ferguson's line. If you put a line through the center of L3 and drop it down, it better be running right through the anterior, at least the anterior third of the sacrum. If not, you have anterior weight bearing, you're biomechanically unstable. That overloads the facet joints here on L5. It's probably why L5 is the most frequently fractured and can blow out the pars interarticularis with this setup. We'll talk, I don't want to get ahead here. Let's see. So increased lumbosacral angle is the same thing. The slide, look at the steepness of the sacral base. Should be about 40 degrees if memory serves. This one's at least 60. So too much slip, it's going to predispose this to slip, puts too much stress on the pars, which is the thinnest part of the posterior arch. So disc herniations are more prevalent here in these conditions as well. What about mechanical factor? Can you think of a mechanical factor? The risk factors place a significant stress on the facets and posterior arch. I think we're still talking about on this. I should have included this in this increased lumbosacral area. I think that's what I was trying to say with that one. But this one, posterior arch may be congenitally weak. You may have a posterior arch that's thinner than normal, hypoplastic posterior arch, which we'll see in a bit. Okay, here's these lines here. You probably already know these, but we should know these again. There's gravity line or Ferguson's line. This right here, we talked about all this. 1/3 of the sacrum. If just this is good enough for me. You don't need to know what's it's going too far. But if it doesn't fall through the posterior one or anterior 1/3 of the sacrum, they're unstable. No, maybe we should know that line, because what if it's just a smidgen here? So maybe that is a good thing. So if the line is greater than 10 millimeters anterior to the sacrum, the tip of the sacrum here, sacropromontory, then they're said to be biomechanically unstable. And we said greater shear force on the L5 disc way overloads the posterior arch of L4 and especially L5. We talked about all that stuff. These patients, how can you tell? They'll be very hyperlordotic, like a lot of gymnasts tend to be anyway. Sacral base angle, I'm not going to go too crazy on this. Sacral angle, still kind of controversial, so it should be around 40 degrees. Will I hold you to that number? You should know around 40 degrees. Normal sacral base angle. Probably already know that anyway. Right, here's one of my clients or patients. So this is obviously, that's that, remember I showed you last week that ONUS software, that free software, you can get nice measurements. So how do you measure the sacral base angle? Is you put a line right down the S1, or the sacral base, the S1 vertebral body, or just the top of S1 here, and then you drop the other line or perpendicular to the earth or the bottom of the film. And this is 55. Does this guy have a abnormal sacral base angle? Absolutely. Now, so radicular pain. So how can a spondylolysis cause pain down the leg? Well, normally it can't because they don't slip, but they can on sometimes, because when the fracture heals, sometimes you can develop a jagged, almost like a bone spur type thing, or the callus becomes very jagged and hardened, and that's called the beak of the spondylolysis. The beak, like a beak of a pelican, or the beak of a woodpecker, better analogy. And here's usually they're more, let's say they're more, how can I say this? They're more inferior to the fracture site, so we wouldn't be able to see them. And they kind of jab the nerve as it runs around the pedicle trying to get out. But here's one I dug up that actually shows the beak of a spondylolysis protruding medially into the canal here. So they can be quite irritating. It's just like a bone spur, and unfortunately there's not a lot that can be done, and they may have to go in there and surgically clean that out. This is called the skip level. Give you a second on what's going on here. Okay, so these are spondylolyses. Maybe a little slip here. Grade 1 spondy here. Definitely a big defect, probably through both pars intra-articulari here. And these, what type of images are these? Well, this is an X-ray. That's why I say through both. This is a CT. Can I say on this CT image, can you see both pars intra-articulari at the same time? Here we can, right? In an X-ray, this is pressed flat, two-dimensional. It's like a person got run over by a steamroller, so I'm seeing both parses here. Here, no, we're seeing one, right? So, not sure which one, if this is the right or the left, but this is only one. Anyway, I digress again. So this is a skip spondylo. These are fairly rare, but these are bad news again. Anecdotally, they don't do well with conservative care. Making the diagnosis. The point here is it's very important to catch these things early, especially in kids. If you can catch them early before a slip occurs, a lot of times conservative care is very effective. But if you don't catch them early and they've already slept, the chances of the patient getting back to returning to sport are not. Did I say slept? Slipped. The patient returning to sport is not that high. All right. Therefore, if you do, I know everybody's gun shy about exposing kids to X-ray, which they should be. But if you have an athlete, he's got low back pain, then you should X-ray the child just to make sure that he doesn't have a spondylo. Because if he has a spondylo, then he needs to stop the sport. You might even need to brace him. We'll actually talk a little bit more about that in a little while here. Alright, so if the radiographs are negative for spondylo, a few weeks of conservative care and restriction from sport is indicated. However, if the patient continues with significant pain, and he has spondylo-like symptoms. What's that mean? Spondylolysis-like symptoms or exam findings. So that's pain on extension. Spondylos hate extension, so you could have a positive Kemp's test maybe, or just pain on pure extension. Then if you've waited more than 6 weeks and the kid's not getting better, he's having trouble, he can't do PE, nothing's showing up on X-ray, then it's time to get a CT, thin slice CT, and see what's going on in there, because he may need to be braced. If the CT is negative and the patient still has just, let's say another 6 months has gone by, you hate to expose a kid to a bone scan, but if it's gone on for 6 weeks and you can't see it on a CT, and you just need to make the diagnosis, then you can order a bone scan. Bone scan's pretty good at picking up osteoblastic activity, and it'll show it. So what do you see here? Here's a young athlete with disabling low back pain. What do you see here? Well, you can see over here what you see here. So here's L4. You can see a spondylolysis right here. Can't tell if it's bilateral or unilateral. So we have reactive sclerosis. See all this white right here? So pretty suspicious for a spondylolysis. Not 100% conclusive. You can see reactive sclerosis here around the fracture site. So there's more signs here that we have something going on. Anybody else see anything weird here that makes this suspicious for a fracture? Even it may be a healed fracture. What's that? We talked about those. It's a traction spur, right? And what I say about traction spurs, those are a sign of instability. So this motion segment is probably unstable. We even have a retrolisthesis, right? It's slid backwards. Traction spur, retrolisthesis, stress reaction here, reactive sclerosis. I bet we have either a spondylolysis that has healed, or maybe it's just not visible here yet. So be careful of those. Okay, so now take a look at this. Try not to look up here. Take a look at that for a second. Alright, so what do we see? Scotty dog, so this is obviously an oblique view. There's the pedicle, superior articular process, transverse process. Pars would be the neck of the Scotty dog, inferior articular process. The lamina, you guys know that by now. Now, look at the size of well, let's jump over here. Look at the size of the neck on this one. There's the eye, there's the ear, here's the neck. Nice normal neck. What do you think about this neck? It's pretty skinny, isn't it? So that's a dysplastic, or in this case, a hypoplastic pars. Is it sclerotic compared to this? Yeah, it's got reactive sclerosis. The facet joint is sclerosed. It's probably a little microinstability here. So that's called a dysplastic pars intraarticularis, or more specifically, a hypoplastic. So pretty suspicious for a pars fracture. How's this Scotty dog's neck looking? It's not looking good at all, is it? The facet is actually right through the neck, so this is definitely a spondylolysis here. Probably some slip in there too, which we can't see. When do you order a bone scan? If the patient has failed 4 weeks of conservative care, including chiropractic, physical therapy, acupuncture, rehabilitation, anything, and he still has disabling back pain, which is preventing him from returning to sport. This can be 4. You can give it 6 if you want. 4 to 6 weeks is probably better. So he can't go back to sports. X-rays were negative, or I guess in this point we haven't taken X-rays yet, but you definitely want X-rays. Oh, I see where I'm getting at. So we've already taken X-rays, which is good, because I said we should take X-rays right away on these kids. CT was done as normal. Then it's time for a spec bone scan. Just bone scan's fine. And by this point, you had better have referred him to an orthopedic surgeon for an evaluation. Even though you feel confident that you can manage this and he doesn't need surgery, you need to be a team player. You need to refer the patient to the orthopedic surgeon just to get his opinion. If not for any other reason, it's part of your due diligence as a primary healthcare provider. You can't just keep patients forever and ever and ever. You have to refer to other members of the team. All right. So how do you manage a spondylo? This is coming from, I don't even want to try to say his Naimadin paper. It's actually a really good paper, though. You can pull it up. We have the spine journal in our medical library, so at Palmer, so you can pull it up. It's a nice read, but I liked it. And here's one thing. I'm going to put this on the final. I'll tell you right now, and probably a third of you will miss it, even though I'm telling you right now. You watch and see. But you do not give anybody NSAIDs. No non-steroidal anti-inflammatories. So that means no Advil, no ibuprofen, same thing. Nothing like that, right? No Voltron. There's Voltron right there. That's the old, one of the strongest anti-inflammatories there is. Even Aleve, no Aleve, Celebrex, nothing. Why? Because it's a fracture, all right? And part of the healing process, if you remember back to your anatomy when you studied bone remodeling, how bone is formed, it starts to form. There's an inflammatory process that occurs naturally and has to occur in order for new bone to form. So, same thing if you've had a fusion. You never take NSAIDs following a fusion. Same thing, you're trying to form new bone, uh, and this will basically it'll stop the formation. Your chances of forming new bone if you take NSAIDs are not very good. So, absolutely no non-steroidal anti-inflammatories. You don't know how many times I've seen patients come to me over the years with a fresh spondylolisthesis, and the primary healthcare provider, the family doc, has given them a prescription for some type of anti-inflammatory. And so, technically, as a chiropractor, we can't interfere with that relationship, but I would give the patient some information and strongly advise them to go back to I would even call the family physician's office and say, hey, can you reconsider that? Give him, if he's not familiar, give him the papers. But I think you know what I'm saying there. But can't have anti-inflammatories with this condition. If they have horrible leg pain associated with this, you can actually try a transforaminal epidural steroid injection. We talked about those before. Make sure it's fluoroscopically guided, right? We don't want, in the old days they didn't use fluoroscopy, and you have to use fluoroscopy so you can see where you're putting the steroid. Let's see, for the back pain, the spondylolytic defect can actually be injected itself. So if you find a good needle doc, they're usually anesthesiologists who are pain management doctors. They're called PM&R doctors. Pain management rehabilitation doctors are real good at this. And obviously, manipulation is contraindicated. Now, discontinue sports. If this is a big problem and they're really disabled, and you want to fix, and they have a nice, unilateral, bilateral spondylolysis, you want to put them in a zero extension brace. They wear it 24 hours a day, 4 to 6 weeks. A Boston overlap brace is good here. We're certainly capable of handling this. You can refer to an orthopedic surgeon as well, just to have another set of eyes on this. But there's one school of thought when insurance malpractice cover didn't like us doing this because they said, well, you're treating a fracture and you're not, chiropractors aren't supposed to treat fractures. So kind of a gray area. So if you work closely with an orthopedic surgeon, maybe send a patient over to get it here. But I think we're okay to do that ourselves for 4 to 6 weeks. We're experts in the spine here. Physical therapy. So what can we do in our office? We can definitely start strengthening the core. The anti-lordotic strengthening. What's that? Anti-lordotic strengthening. So what can kind of decrease your lordosis if you increase the strength of your rector spinae muscle? So we can do that. You have to be careful though, right? You have to do the strengthening isometrically. Okay, there's a good test question. You can't do it concentrically, eccentrically. It has to be isometrically. You can't extend. The patient must avoid extension. So you can't have them go like on one of those Roman chair sit-ups where they do hyperextensions. They cannot do that. But you can still strengthen them isometrically. And again, no manipulation. So after 4 to 6 weeks of the aforementioned therapy, patients symptom-free, fantastic. They can return to sport wearing a softer brace. They can continue, but they should continue physical therapy in close monitoring. And you can actually progress to the more active type core strengthening. Now, after 4 months or so, a follow CT should be ordered. Now, I don't know if I agree with that. If the patient's doing good, there may be no reason. Remember, these are recommendations. These were MDs who did this study. So you may not need to do that if everything is going fine. So that might be a little overkill there. But wean the patient off the brace and return them to full sport and see what happens. Now, if the CT, however, shows non-union, and I would assume the patient would be symptomatic here, uh, and the patient continues to be symptomatic with non-union, then you're in trouble. This is controversial. They used to use electric bone stimulators, which so they work with fusion. So I don't see why they wouldn't work in this condition. Insurances are still dragging their feet on this. So here's some research on it. So this meta-analysis couldn't really conclude whether or not it would be useful. But even though there's a paucity of research, what's that mean, paucity? That means it's scarce. There's not a lot of it. But it makes logical sense because bone stimulators work for lumbar fusion and extremely stubborn fractures. So I just don't think we've had enough good studies to make an opinion, which was kind of the point of this study. But they have appeared to grow out of favor. So although the majority of spondylolysis patients respond well to conservative care, if surgical treatment's indicated, then it's indicated. Sometimes they just need it. If their oswestry is real high, over 50, and nothing is working, if this is going on for 6 months, they may need to have that slip reduced surgically and stop that micromotion by fusion. Especially if there's a progression of the slip, if things are getting worse, or if neurological symptomatology arise. That's obvious. Surgical procedures, let's talk about those a little bit. We're experts in the spine. We need to know a little bit about, got to know a little more than just adjusting the atlas, I think, to help your patient. You're the quarterback. You need to know this stuff. So there's two surgical procedures. There's a direct repair method. There's a there's a direct repair, and there's a fusion method. There's different fusions. This is controversial as well. Let's talk about direct repair. So here's the Bucks procedure. There's some other old wiring procedures. Let's just stay with the Bucks. This is kind of the new procedure here. I won't get into all the other ones, but what they do basically is they screw it. They put screws. They use stealth. There's stealth CT technology where they can see exactly where they're drilling, and they can very carefully drill a hole right down the posterior arch, right through these fractures, and then they can put titanium screws in there. Now, some of the newer docs are experimenting with a biologic called human recombinant bone morphogenetic protein 2. Let's just call it BMP2, which theoretically should increase the chances of this procedure working because it causes bone growth like crazy. You can go on my webpage and read more about that. There was a big cancer scare, however, about the use of BMP, so it scared all the surgeons away. Not all of them, some of them are still doing it, but it scared a lot of the surgeons away from it. Now the research is looking like maybe it was a henny penny skies falling kind of a thing. We're still a little skeptical, but it looks like maybe it doesn't cause, especially at low doses, it's safe. But it sure encourages bone healing and would be ideal for something like this. So anyway, let's see, I talked about that. The ODI should be very high, right? For fusion, that's why you always give patients that oswestry, because they want to play football so bad they'll do anything. But if their oswestry is only at 20, it's ridiculous. A successful surgery typically gets the patient down into the 20s at best, and the hump of the bell curve. So make sure we need to know what their definition of pain is before we start ordering stuff. Okay, here's go to Radiopedia, you can see a nice example of a spondylo case. That's a great site, by the way. Radiopedia is just full of great cases. Docs are uploading from all over the world. You can learn a lot. You could easily put together a whole radiology class just from this one site. Okay, let's move into spondylolisthesis. Maybe I'll stop the tape here and make a new one. Not sure how long it's going, but okay, let's talk about spondylolisthesis now. Okay, we just talked about spondylolysis. Now we have different flavors of spondylolisthesis. So we have an isthmic spondylo, a degenerative, a traumatic, a pathological, iatrogenic, a dysplastic, or congenital. I don't like the word congenital though, but because then people think they're born with a spondylo and you're not. Remember the last tape, a spondylo is a stress fracture. It's acquired. They're not present at birth. All right, so let's see. The flavors of spondylo again, the Wiltse classification, Newman and Wiltse. Now there's been modifications on this over time. I like this classification system. It's pretty simple and straightforward, and this is a good one to use. I'm pretty sure the boards will not get into those more complex. This is probably all the complexity you'll need, and that's perfectly. This is a great system. So we have an isthmic spondylolisthesis, which you're familiar with. What is an isthmic? And this is, we're going to go into some of these more in depth, but just a nutshell, it's a stress fracture of the pars interarticularis. This is most of the cases you're going to see are isthmic spondylolistheses. Now you may have a pars elongation. Pars elongation. So what is that? It's still an isthmic spondylolisthesis that has healed. Remember, we saw a couple examples of that in the first part of this lecture on spondylolysis. Might be just sclerosis there, but especially in an athlete who has hurt their back over and over again. Each time it heals, the pars gets a little bit longer and a little bit longer, and that is a pars elongation. Now you can have an acute fracture of the pars from trauma. This is actually very rare. If you're going to have trauma to the spine, it's probably going to be the transverse processes, the spinous process, the vertebral body. It's not typically the pars interarticularis. Degenerative spondylolisthesis, because of degenerative joint disease and degenerative disc disease and severely degenerated facets, the facets can become so degenerated that they allow a slip to occur. Okay, so that's a degenerative. This is seen in people 56 years old usually. These are usually seen in younger people. Traumatic, trauma to the posterior artery facets causes a fracture and slip, but not to the pars. That's a good test question, right? Traumatic spondylolisthesis does not include a acute stress fracture or acute fracture of the pars, like a traumatic fracture. That's still considered isthmic spondylolisthesis. Pathological fracture, maybe you have cancer that has wiped out the facet joints or the pars region. Some osteolytic lesions have taken it out. You can get a spondylo from that. Iatrogenic is a common one. People who have fusion, right? An interbody fusion will greatly increase the load of the pars above and or below the fusion level. You can overload the pars, fracture it, and then you get a slip. So that's an iatrogenic slip. And a dysplastic, so that is a malformation of typically L5S1 of the facet. And there may be no facet there. And these are the ones that you see huge slips on. They're very dramatic looking. So this is a dysplastic or congenital slip. So, and it's, yeah, we'll talk more about that. So the two main ones that we'll see, our bread and butter, probably 95% of the spondylos that'll come into our office are isthmic or degenerative. I've learned that most, even spine specialists, with the exception perhaps of surgeons and maybe physiatrists, most spine specialists don't know much at all about this. And as the baby boomers get older, these degenerative spondylos are going to show up more and more. And just from the few classes I've had, the students really don't know anything about this. Everybody knows about isthmic spondylolisthesis, but we need to become very familiar with degenerative spondylolisthesis. What's going on here? Well, how's the alignment? Let's check where the posterior longitudinal ligament would run. So we definitely got a slip. We got a grade 1, getting close to a grade 2 spondylolisthesis. Schmorl's node, discopathy, the disc is thin. So, grade 1 spondy. So, now this is an important note too. Spondylos are not always symptomatic. So, some studies have shown that that the majority of spondylolistheses, over 50%, in fact, are not symptomatic at all. So these are big population-based studies. Unfortunately, this is not true for athletes. The most the tides turn much less than 50. It's much higher when you see a spondylo in an athlete. It's not. It doesn't always mean it's symptomatic, but chances are it's been stirred up and it's become symptomatic. So with adjusting, I'm harping again on adjusting. Be careful not to make an asymptomatic spondylo symptomatic through adjusting, right? You don't. That's why it's scary sometimes to adjust people without taking radiographs, because you just don't know what's down there. People get sued every year. Chiropractors get sued every year for lighting up a spondylolisthesis bad enough for surgery. I just saw a case last month about it. So it happens all the time. This is the famous Jensen study. There's a lot more since this. I always put this in here because it's, this is the New England Journal of Medicine. This is it, the granddaddy, the probably one of the best peer-reviewed journals around. And like I said, there's other bigger studies, but Jensen was the first. And so what he did is he took almost 198 completely pain-free people, just picked them in a row, aged 20 to 80, perfect, a mean 42 years old, and they did MRIs, and it was very strange because 7% was the magic 7% came up. 7% of those people had spondylolysis, 7% had spondylolisthesis, 7% had central stenosis or lateral stenosis, so very strange, and 30% had disc hernia or disc protrusion. So bottom line is, just because you have one doesn't mean it's symptomatic. I think we need to go over this in case I talk a lot about prevalence and incidence, so I'll let you read through that. I might even put a question on the test, you never know, so I'll let you read through that. There's a YouTube video on this that's real nice. How incidence is the amount of disease coming in, spondylolisthesis we're talking about. The new spondylolisthesis coming into the prevalence is the population. It's always going here. The only way the prevalence decreases is you're either cured through surgery or treatment, or you die. Well, in spondylolisthesis, you're not. The only way you're cured really is through fusion, because conservative care might help your symptoms, but it can't fix the spondylo. Anyway, isthmic spondylolisthesis. So we know what that is. The top vertebra slips forward on the bottom vertebra. So it's usually caused by a fracture of the pars interarticularis, stress fracture, acute fracture, elongated fracture. Talked about this, right? Starts out in childhood as a pars or spondylolysis. Typically will start in childhood again. It's very rare for these to light up in an adult. We talked about the cycle of healing, fracture, healing, where the pars can get elongated. Similar stuff to what we've seen with spondylolysis. Again, common at L5. The point prevalence is 3 to 8%, much higher in athletes. The spondylolysis prevalence 6 to 12%. High risk sports, again, football, gymnastics, same things, same ones as for spondylolysis. Now here's a very famous study. This is the Fredrickson study, and we're going to talk about this a little. Fredrickson Beutler study. First part, they x-rayed 500 children. I said this in part 1, I'll say it again. They x-rayed 500 children and followed almost all of them who had pars defects for 45 years. 500 children. They also did 500 where's that? There it is down there. They also did 500 newborns, not the same children though, but they did 500 newborns, and not a single case of spondylolysis or spondylolisthesis was found. But this is pretty remarkable. They followed 500 children for 45 years. The ones who had spondylos, a lot of them dropped out. The ones who didn't have spondylo, a lot of those dropped out. But they did keep a lot of these. So what did they find? So 4% of 6-year-old had a spondylolysis or spondylolisthesis. But the vast majority of these kids had no symptoms. But yet here's 4%. Now 81% of those affected with a spondylolysis or spondylolisthesis had a worsening of the slip, or the spondylolysis progressed to slip by the age of 25. 52% of those affected reported episodic low back pain over the study period. So almost half of these patients with a spondylo had back pain. That's higher than the normal population would you'd expect from a normal population. And here's a disturbing number: 10% of them succumb to spine surgery. That is much, much higher. Maybe the general population is probably 1% or less. So that's a big number there. So why the slip? Why does the darn thing want to slip anyway? Well, we know that the posterior arch prevents the slip, the facet joints, and the posterior arch itself. So let's see. So I didn't talk about this before, the lower 3 lumbar vertebrae, as well as the upper ones, they have a natural tendency to slip, or they have a tendency to want to slide down the hill, like a kid with a sled. He's up on the top of the hill, he wants to slide down the hill. So there's a natural tendency for this anterior translation, and that slip is called anterior translation. The facet and posterior arch normally stops the translation. Defects in either results in slip, which may be stable, may not be stable. Why do you get the pain? So we talked about abnormal micromotion at all. There might be macromotion at the fracture site. See, there's a fracture. So micro movement within a fracture. There's pain fiber in here, right? Periosteum is highly innervated, so that can cause back pain. Then we talked about the beak in the last video. You can grow a little point, and this is supposed to be going into the plane of the page and shish kebabbing the traversing nerve root as it comes down, sometimes from the point of takeoff. So that's the beak. So can a spondylolysis, that sounds like a good test question. Can a spondylolysis without slip, can that cause radicular pain? Absolutely, via the beak. Talked about the beak before. There it is. We talked about that in the last video. So sometimes these spondylolyses, well, often, almost all the time, there's a big fibrous plug, like surgery. You go in there and you can see them pulling out all this pannous fibrous tissue. But this tissue itself may become infested with nociceptive fibers. Angiogenesis will grow into this tissue, and the nerves will follow. So you can literally become wired for pain, just like a disc hernia, a disc tear. When it heals, nerve roots or nerve fiber grows down the disc tear. Same deal here. Let's see, do we need to say anything here? No. Talked about all that. Clinical presentation, we've talked about that before. What's that? That's that step sign. So if symptomatic spondylolisthesis typically causes low back pain, true. Not radicular pain in and of itself, unless there's a beak, or unless the slip is so bad that it's compressing the nerve roots. But again, the spondylolysis or spondylolisthesis itself, the fracture site, doesn't cause radicular pain. It's a sequelae. What's a sequelae? That's the outcome that causes it. Because the posterior arch is fractured, central stenosis typically does not occur. Is that a true statement? Yeah, that can be true. Now you may get some referred pain into the buttocks or groin from a spondylolisthesis, just like a disc or a facet or the SI joint. The fracture site can refer pain as well, but it's not going to go below the knee. So more radiographic signs. We saw the Scotty dog, we know, fracture. Greyhound sign, what's that? That's an elongation of the pars where the pars, that's an isthmic spondylolisthesis, that's healed, broken, healed, broken, healed. That's the greyhound sign. Reactive sclerosis we talked about. Napoleon's hat, we know that. That's that upside down sign at L5. Spondylopitosis, what's that? That's a complete slip right off the pedicle there, or right off the podium. There's a step sign, stair step sign right here. Looks like I forgot to put that in. I'll have to fix that. Non-surgical treatments, again, we talked about bracing in the last tape. I'm not going to go through that again. We talked about avoiding NSAIDs. Right, we talked about all this stuff already. Surgery. Now surgery's the end of the road, of course. The oswestry had better be over 50. So now this is a, you can see, what is this? I'll ask you what this is. We've talked about this. So this is some type of interbody fusion. Here's the pedicle screws. Here's the rod stabilizing these two segments. What segments are fused? L4 and L5. If you look closely, you can see some little markers. See those two dots? So there's a caging there. So this is an interbody fusion. There's a blow up. You can see the cage here again. Notice that they usually are not able to completely reduce the slip. The best hope is to stabilize the slip. So what are these things? I've put this on my test before. What are these things? Those are cage markers. So this is a polyether ether ketone cage, or peak cage, and that's just where it's placed. Placement looks good. Degenerative spondy, okay, important one. We don't know much about this thing. So what do we got here? Let's look at this for a minute. Well, it's axial view. How's that disc look? Don't see any herniations. Follow the back right along. There's the thecal sac right here. Squished, isn't it? All right, it's T2 weighted image. We should be able to see the nerve roots in there. So we have what? Severe central stenosis. We got pretty severe lateral stenosis. We got a bulging disc. What are these things? That's ligamentum flavum thickening. So ligamentum flavum is thick. So we got central stenosis, but we got something we haven't seen before. So look at the posterior arch here of this. If this is L4, the L4 posterior arch. So we have, here's inferior articular facet, superior articular, process, inferior articular process, superior articular process. Look at what's happened over here. Whoa, now we got a big slip. So there's no fracture through the pars is good, but the whole posterior arch has slid right off this facet joint. So this is a degenerative spondylolisthesis. It's a big one. Okay. So in order to make the diagnosis of degenerative spondylolisthesis, you must have an anterior slip, spondylolisthesis, significant facet degeneration, and there cannot be a fracture or any other anomaly of the posterior arch. It's almost always associated with ligamentum flavum thickening and disc bulging, if not herniation. And the disc is typically thin. That's why sometimes if the disc collapses, the tension on ligamentum flavum is decreased, and they tend to get thick in response to that. Typically strikes in the 60s. This typically, unlike the spondylolisthesis, spondylolysis, the isthmic, this one occurs more frequently at L4, especially likes middle-aged females with hyperlordotic lumbar curves. Typically don't say never, but typically will not go more than 50%. Cause is unknown for sure, but some have theorized there's a subchondral osteoporosis of the facets has been proposed, which has led to microfracture and facet deformity. We know the facets give out. They fail to do their job. They fail to hold the posterior arch from slipping or stop the posterior arch from slipping forward. Not exactly sure the pathophysiology of that yet. Okay, here's another one, different patient. So not as severe. Look at the ligamentum flavum thickening is real bad here. Right, but you can still see the T2. There's still some white color in there, which is good. This IVF is open, but this is definitely slid. So we have a slip right here. Not as bad as the last one, but this is more like the ones you're going to see. But look at the facet. See here, the facet joint. There's a little ligamentum flavum thickening, but look at the bone. You can kind of draw a curled line here, a curved line. Looks good. Here, you got a big jagged line. So there's definitely a slip there. That's a degenerative spondylolisthesis. Risk factors. Hemisacralization. We've talked about this before. It's a nice picture of unilateral spatulated transverse process, hemilateral sacralization of L5. Facet tropism, hyperlordosis. I would know this slide. These are some risk factors for the development of a degenerative spondylolisthesis. And status post fusion, right? You have an iatrogenic slip that can overload the facets. Treatment is the same. I'm not going to go through this again. Same deal. Same deal. Don't give them steroids. Although this one, now let me think about that. This one I think you can give them steroids, right? I should probably take this slide out because this has nothing to do with a fracture. So I need to take this slide out. You can give them steroids. In fact, that'd be a good test question. Someone with a degenerative spondylo, you can give, well, you can't. They can take over the counter. Our scope allows us to say they can take over the counter NSAIDs, or go to the family team member, the family doc team member, and get a prescription for some steroids to help our therapy along. Surgery, same deal. Interbody fusion. That's kind of beyond the scope. I have a whole page on this on my website, so you can look about it more there. Hey, we're done. Okay, so I will make not right now because I'm exhausted, but later on today I will put that quiz together for you. And good luck on your final. Remember, all of this stuff is fair game for the test. I will put a PDF of this PowerPoint up on the website so you can take notes on that. And we'll see you in the next video.